You're listening to the Sick and Good podcast. My name is Dustin Messick. I'm a registered dietitian nutritionist and a cancer survivor.
My name is Colin Goodwin. I'm a clinical psychologist and a cancer survivor.
In 2024, we are highlighting the Cancer Awareness Months in a special series.
We're promoting wellness by having discussions on screening, treatment, and recovery throughout the cancer journey.
To find a balance between sick and good.
That during the cancer process, both can be true.
The Sick and Good podcast is for educational purposes only. The podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition or treatment, and before undertaking a new healthcare regimen.
I'm pleased to introduce our guest for today. Dr. Rushil Patel is an assistant professor of medicine at the O'Neill Cancer Center at the University of Alabama, Birmingham. His clinical practice focuses on patients with hematologic conditions. He is interested in developing culturally concordant models of palliative care, minority groups or minoritized adults within corporate, religion, spirituality considerations. Welcome, Rushil.
Good morning. Thanks for having me.
Wanted to just ask what sparked your interest in oncology?
Sure thing. This takes me back to, I guess, what would now be about 10 years ago when I was still in medical school. I had a background in, coming into medical school, I had a background in biochemistry, which included genetics and basically things that we couldn't necessarily see. And I really wanted to be, in the field of medicine, just sort of being able to translate, interpret the basic science into ways that can shape somebody's health and guiding them through management. And I was really drawn to sort of behavioral considerations of care. So for some time, I was actually considering, psychiatry, neurology. But it wasn't until I think my third year of medical school when you actually get away from the lectures, start spending time in the hospital and seeing like the different specialties that I really became drawn to medical oncology. Because there I saw this intersection of the psychosocial aspects of care, along with sort of those basic science interests of biochemistry and genetics. And I would remember in particular, this one gentleman, he had advanced lung cancer, was admitted to the hospital, and just how the attending who had known this gentleman for some time, sat down with his wife, and he was very, very ill, and sort of, at that time I didn't recognize it, but very skillfully broached the topic of this gentleman is nearing the end of life, and what would be most important to you all. And it was very clear that they wanted to be at home and not coming in and out of the hospital, and ultimately went home on hospice care. And like I said, I just go back to that experience, and I think that's really what drew me into medical oncology, was just seeing that intersection of the psychosocial aspects of care with sort of those basic science interests that I had, and then being able to guide people through it. And I think from there, I actually became drawn to palliative care, because it was around that time that I came to meet, or I came in contact with Dr. Andrew Epstein, who's a gastrointestinal oncologist at Memorial Sloan Kettering Cancer Center. And he actually does both oncology, medical oncology, but he's also been trained in hospice and palliative care. Palliative care, for those who might not know, it's specialized care for anyone that has any kind of life-limiting illness like cancer, where it's really patient-focused. So much of medicine is focused on the disease or condition, but it's really trying to highlight patient, addressing sort of the physical, like symptom burden, the psychological, religion, spiritual considerations, and really trying to help people basically go through illness at any stage, especially as they approach the end of life. And so that's how I went from medicine into these two fields of medical oncology and palliative care. And I would say this was, I didn't mention I did medical school at University of North Carolina, Chapel Hill, and then I did residency in Greensboro, North Carolina. But it was around this time that I went into this.
So, Rushil, you kind of talked a little bit about this lightly, but I was curious, what has been your interest in religion and spirituality in oncology?
That's a great question. And at this point, it's probably worth highlighting that I did all my college and medical school training in North Carolina. I also did my adult medicine training in North Carolina. And throughout those 5 years of medical school, 3 years of adult internal medicine training that you do after medical school, I never really thought about religion and spirituality at all, even in just medicine in general. Really, this interest in religion and spirituality kind of emerged when I decided to do hospice and palliative care fellowship training at Memorial Sloan Kettering Cancer Center in New York City. And to go from North Carolina to New York City, it was sort of immersed in a very diverse, culturally diverse patient population in the hospital. And our palliative care service, seeing these patients in the hospital, a lot of times we were called to manage symptoms, but we realized that there were other considerations, like I addressed earlier question, like faith-based considerations. And I just thought it was amazing that we worked with such like an interfaith, well, it was an interdisciplinary team. So we had chaplains, social workers that we worked with, but even amongst the chaplains, like we had rabbis and imams, as well as people of various Christian traditions, all practicing, all working to serve these patients that we saw. And it was really at that point that I think these concepts of religion and spirituality sort of came forefront in my professional career. Now, obviously, faith is something that's important to me outside of work and sort of shapes my identity, even as a just like a citizen society, as a family member, and so on and so forth, and even how I practice medicine. But I never thought about faith in the practice of medicine until my training in palliative care. And I even saw how these considerations emerged. I still remember there was one gentleman who had been admitted with advanced sarcoma, which unfortunately was in his chest wall. It was like involving his heart. At this point, he had no additional cancer treatment was felt to be safe for this gentleman. But unfortunately, his goals were very clear. Like he wanted to leave the hospital, but his family members, there was a conflict between his wife and one of the children about what to do next. And so he could not leave the hospital, and he just continued to get weaker and weaker and just could no longer be able to actually communicate. So I still remember that morning coming in as palliative care clinician on the floor to try and help this gentleman. And some of the mixed signaling that was coming about the medical decision making was because the daughter who described who identified as a Orthodox Jew, she was working very closely with her rabbi and sort of making some of this medical decision making. And so I remember walking to the room, and I think that at that day, the nurses in particular were in so much distress, as were the team that was tasked with being the primary service, because the gentleman, when he was still able to speak, had elected that if it came to it, he would not want to be resuscitated, would not want intubation, would want to go home with comfort-focused measures. It was home hospice if possible, but otherwise just comfort-focused measures. And she rescinded all that because he could no longer speak, and was doing this in collaboration with the rabbi that she was working with. And in my conversation with her, I was trying to understand, can you explain to me kind of why you rescinded this? And she felt that people had just given up on him. They weren't checking his labs. They weren't checking his heart rate. And she just thought, by me rescinding this DNR, do not resuscitate order, that people will start caring about him much more closely and carefully. And I told her that order doesn't preclude them from doing those basic things that you just mentioned. We can still check blood work if that's what you're concerned about. But then, she looked at me and said that, I can tell that you're a person of faith. And she saw the religious symbol that I adorned on my forehead. And she's like, I can see that you're a person of faith. And I really believe ultimately it's going to be in God's hands. If a miracle is going to happen, I think that's something that you can understand as a religious individual yourself. And that was probably the first time, I think, in the mix of all this, that somebody had invoked religion and then invoked me as somebody who identified with a religious tradition to try and understand like the complexity of what was actually happening. And so it was at that point that I had to speak in the language that she brought forward. And I said that something that I'm taught in my faith as a Hindu by my spiritual leader, Swami Maharaj, is that the fruit of all wisdom and learning is humility. And we as clinicians have to be humble about the treatments that we offer and the limits of those treatments. And I expressed my concern that some of these interventions and things that she was hoping for, going to the ICU, doing all these things that her father had made very clear that did not want to do, are going to have a negative effect. But nonetheless, she heard what I had to say, and we acknowledged to disagree. He was transferred to the ICU later. And then that evening, I went back to see what happened. And I think she realized that her father was in the last moments of life and ultimately ended up reinstating the do not resuscitate order. And he ended up passing very peacefully in the ICU without having any of those other interventions. There were so many examples like this where I felt like these considerations were clearly important. They were in the background, but for whatever reason, the medical system couldn't be proactive and bring these considerations forward. Like, how much easier would that encounter have been if the medical team had actually invited the rabbi to the conversations about what was actually happening with this gentleman? This gentleman had been there for weeks, and yet, like, all this stuff happens in the last minute. Thankfully, she ended up acknowledging her father's considerations. But I think that's when it really started occurring to me that we're really missing a lot of patients, their wishes and their preferences by not including these considerations into our the way we care for patients.
What a wonderful example of compassion and just having that conversation and being able to really explore. To me, I'm hearing that it's a difference of wants. There's the want of the patient versus wants of the family. In both circumstances, they're just saying, I want to be heard. The patient saying, I recognize that I don't want to have these things that are going to be traumatic or these efforts to prolong my life, because at this stage there's maybe some more of acceptance. And it's maybe another thing to then point out that there's that difference in that acceptance with the family, the wanting to be heard that this is not the last stage of their life and there are more things to be done.
Yeah. And I think it's those moments that when I reflect back, I feel like in medical school, we are taught so much about interventions, like how do you manage the condition? Somebody has high blood pressure. Somebody is having respiratory failure, like they need support, you intubate them. But I think once you leave medical school and you start taking care of patients, you begin to realize that there's a whole layer, there's so many factors that go into whether or not an intervention should be offered. And I think one aspect of that is how people make decisions. And for some people, it's working with folks in their faith community and hearing maybe experiences. Because I think a lot of people, they rely on their faith communities in different ways. Sometimes it's more active, like in the example I shared, where there's somebody actually actively participating in medical decision making. Other times it's just sharing experiences with disease and illness, and sort of that guides how people make decisions. And other times it's just having a shoulder to lean on, because we as clinicians come in, tell somebody what's going on, and we walk away to take care of other patients. So it's sort of that support. And I think it's these sorts of experiences that really cemented in my mind that I just feel like as the American healthcare system that we have, this modern sort of biomedical model, we don't really incorporate these considerations, and then we scramble when they get thrown in our face at the last minute. And then there's a lot of distress, I think, on the clinician's part of offering these interventions that we know aren't going to help the patient, when if we could just have gotten everyone on the same page from day one, it would make that conversation so much easier.
I wanted to add a response as well. What you're sharing actually reminds me of some of my volunteer work when I did hospice. I used to volunteer as a spiritual meditation kind of person in hospice. And I came in, at the time I was practicing this thing called Reiki. I don't know if you've heard of that, Rushil. It's just a Japanese word for universal life force energy. And it's kind of like a healing meditation. And just hearing you speak, it kind of reminded me of this time I came in with this. I'm like, oh, this is the secret, because it helped me with some of my pain management when I was doing my cancer treatment. I don't really practice it anymore, but at the time it was helpful. And I had this patient that I was assigned to. I would go and visit her once a week. And actually what helped her most was me reading to her in her spiritual book, which was the Book of Mormon. And she was not open to what I was doing at all. She just wanted her spiritual book. And actually, from me going once a week, her daughter called me up and was like, I don't know what you're doing, but my mom is my mom again. And a couple months after that, she actually got better and she left hospice care. So I don't really know if it was what I was sharing or if it was just her having that feeling of overall good well-being from like being close to her faith through hearing like the word of gospel that's connected to her, like religious heritage.
Indeed. And, it actually reminds me of another example where I don't know if any of you have read Atul Gawande's book, Being Mortal. I think it was published probably about 10 years ago, 2015. In there,
fantastic book.
Yeah, exactly.
I really enjoy it.
Yeah, and I don't know if you remember that story with the nursing home where you had all these adults with dementia, advanced dementia, and then I think one of the administrators in that nursing home realized that there's just no life in this nursing home, and so they got, I believe it was pets like birds or dogs or I don't know. They had different animals, and they tried to put those people's rooms, and they found that people became more interactive just because that there was something living close by and they were able to sense it. And so I do think it's so easy, I think, when we look at somebody and they're like, and it feels like they're not verbal, they're not able to communicate with us, they're too ill. And then when we surround them with something that gives them vibrancy, in the story you shared, Dustin, it was for this woman, her faith, something that recalled like a prior memory. I do think there's a subtle form of healing that happens there. That's something outside of what any medication I give can do.
Well, I'm very interested in hearing about your research on the intersection of cancer and Dharmic faith.
Sure thing. And I think as I think back to sort of the training, it was as I was seeing more and more of these experiences as a fellow, a trainee in hospice and palliative medicine at that cancer hospital, he also began to make me wonder what I knew about these sorts of considerations or what other people had noted about these sorts of considerations for my own tradition as a Hindu. And so I think just to kind of give some background, when we say Dharmic family or Dharmic traditions, so just as like there's the Abrahamic family of faiths, Judaism, Christianity, and Islam, there's a family of four faiths found in South Asia that are collectively referred to as Dharmic faiths or Dharmic traditions. And this would include Hinduism, Buddhism, Sikhism, and Jainism. Some of there's certain concepts that are similar to all four, but there's also concepts that are different. And so I think all of us as trainees had to give a lecture. We call it grand rounds and training, where you summarize sort of what we know about any kind of topic. It's supposed to be 45 minutes, 15 minutes for questions and answer. And so I thought, why don't I look to see palliative care research? What have people come across with Dharmic faith? And I really focused on Hinduism because that was the faith that I knew the most. And it's something that I grew up with. And when I was looking through, one, there wasn't much. And then two, what was a little bit puzzling / disturbing to me was that a lot of what was there was just sort of individual opinion, sort of things that weren't really rooted in the reality that I grew up with or knew. And nonetheless, I presented all of this to the audience. And I remember one of the questions that was raised was, should we be doing more for this community of patients? Because clearly you've highlighted there's a gap in knowledge. We don't really know much more. At that time, the only approach that I could tell everyone was like, we should be humble and learn from the patients and families and try and accommodate the requests. But that last question, which was posed to me, is like, should we be doing more? It really bugged me, even after the lecture for like the next several days, to the point where I was like, I wonder, here being in New York City, where you have a significant population community of these four faiths, I wonder how this hospital has done and served. And then it occurred to me, I was like, if you look at all the chaplains, they all represent Abrahamic faiths. None of them represent these four faiths, even though the chaplains are skilled to address spiritual care and address spiritual needs of patients of all faiths. That's how I think my interest in research sort of began. So after my 1 year of clinical training, I stayed on for another year to do research. This would have been July 2019 and to June 2020. So it was what we now know as the onset of the COVID pandemic in those last 6 months. We did basically a 2-part study where we looked at 5 years of people, like the last 5 years, so 2015 into 2019, 55,000 patients were admitted. We looked to see how many of them were seen by a chaplain, how many of them were seen by a palliative care clinician. And then also in the chaplains who saw them, we wanted to see kind of what were the needs that people were expressing. So we looked backwards in time in part 1. And then in part 2, we looked and this would have been January to June, which coincides with the pandemic, we actually interviewed 22 patients and all 11 chaplains were at that hospital to also see what their perception of spiritual care, chaplaincy looked like while being in the hospital. And so with part one, with 55,000 patients, we identified a little over 1,000 who identified with one of the four Dharmic traditions. And what really struck me was that whenever people come to the hospital, there's a series of questions that are asked about, is religion and spirituality important to you? Do you feel like your needs are being met? And based off of that, they either screen positive for unmet needs that need to be addressed by a chaplain. So there's an automatic referral that's put in the system versus somebody who might not have any needs and no referrals put in. But after we looked at the proportions of patients who had needs, I mean, it was close to 90% people who identified with those four Dharmic traditions versus everyone else. It was around 90%. There weren't significant differences. But we did find significant differences in how frequently people used or seen by a chaplain. So when we actually looked, so we didn't really see that many differences. Like I said, it was around 90% in both groups in terms of people who had unmet needs, which is a really high number to begin with. Like 9 out of 10 people coming to the hospital were having unmet spiritual care needs. But then when we actually looked at how many of those people, Dharmic traditions versus all other religions, were being seen by chaplains, it was 37% all of the religions and 32% Dharmic religions, which when you look at a sample size of 55,000, it's considered statistically significant. And so then the question becomes, was there other factors that could account for this outside of religion? Like how long people were in the hospital, how sick people were. And we did adjustments for all those different variables, and we still found that religion predicted whether or not somebody was evaluated by a chaplain. So that was a very interesting finding that came out of this. We didn't see the same signal with palliative care utilization, like whether or not somebody saw a palliative care clinician. And then when we actually looked at the chaplain's notes to see, what exactly the Dharmic religion patients who were actually seen by chaplains, what sorts of things were they actually coming up with? And one of the most common requests that came up with were ritual care. So these would be things like scripture or different articles of worship, different objects that might facilitate somebody's ability to offer prayer. But the one thing that caught my eye was there were multiple requests to the chaplains about identifying people from the community who were related to their faith, like from the local Mandir or a Hindu temple or Sikh or Buddhist or Jain, these four faiths. And none of those requests, at least from a documentation from what was written in the chart, were actually acknowledged. And so it was really, I think it was just sort of eye-opening for me to see that these requests were there, but I couldn't find any evidence of whether or not those requests had actually been honored. And then I think the most stunning result as well as a consequence of these was we also looked at outcomes at the end of life for all patients. And so these are like accepted measures by professional societies within cancer research. Things like how many people got chemotherapy in the last 2 weeks of life, how many people were referred to hospice in the last 3 days of life, since hospice is supposed to be for the last 6 months of life, how many people got late referrals, or whether or not people died in the hospital or ICU in the last month of life. And we found on every one of those measures, people identified with one of the four Dharmic traditions actually had worse outcomes by those metrics compared to people of all other religions. So there's a lot, I think, from just the quantitative measures to really unpack there. And so the nice thing is with the interviews, it helps to kind of put some of those statistical findings into context. And so one thing that came out, we interviewed 22 patients. All but 2 of them were Hindu, and then 2 were Sikh, and sort of asking them about this concept of spiritual care, chaplaincy. I think one, they found both. Some of them were kind of confused by the question. When we said the word chaplain, a lot of times they would think of like a chapel, place to worship in the hospital, which for them sounded very Christian oriented, and so didn't really appeal to them. And then this thing of spirituality, which I think in the West we say a lot, it was something that they found a little bit confusing because I think the split of religion and spirituality is something that we find here, which may not always reflect how faith is constructed in other parts of the world. So there's that piece of it that came out. I think some people brought up the fact that practicing their faith in the hospital, they weren't sure that was something that they would feel comfortable doing, noting that they're in shared spaces with other patients and then people of other faiths in the same room, whether or not they would feel comfortable if the patients themselves, had their articles of worship and were praying in their own way. Again, these are things that I don't always think about as a physician. So I think those are some important things that came out of the interviews. And then the other piece of the interviews, so the 11 chaplains that we interviewed, which was, again, I mentioned before, none of them identified with any of these four Dharmic religions. When we asked about sort of their familiarity with the faiths, I mean, collectively, they felt they knew less about these four faiths. They knew relatively more about Hinduism and Buddhism than Sikhism and Jainism, but they just felt overall they didn't have as much of a background knowledge. Some chaplains felt sometimes the patients would, when they would approach them to come in to the room to offer spiritual care, sometimes patients and families who were like, thank you, but no thank you. Like they would say very politely. There was never any kind of resentment or opposition from them. And then other times, the patients and families were very genuine and appreciated their presence. But I think collectively, the chaplains really felt like they could do more. And some of the things they said specifically were to try and improve the training that they get as they become a chaplain. Some of them even identified trying to find chaplains who identify with one of these four faiths, just so people in the hospital had somebody familiar that they could reach out to. And I thought the one that really struck me, kind of going back to how I mentioned not having community leaders or faith-based leaders in the community that the hospital could call upon. Some of the chaplains brought this up they were very precise in some of the barriers that they'd encountered in the past with trying to acknowledge these requests. One was that the hospital didn't have like an active network of these individuals out in the community. And so the chaplains would be scrambling, trying to Google to find like the local Hindu temple or Sikh place of worship to find somebody. Two, there's the logistical issues of being in Manhattan with parking and trying to get somebody that might be out like on Long Island to come in to the city. Three, there's obviously the issues of privacy. With have a small community, is it acceptable to take that risk? Like, does the patient, maybe they had disclosed their illness to their other community members, and then suddenly you bring someone in and it's a shock for everyone. And then four, the person you bring in, are they adequately trained to do the things that the family and the patients are requesting? So there's a lot of, I think, these considerations that came up that, again, as a clinician, I'm not seeing or thinking about actively, but it just opens the door for opportunity for improvement. I think all the chaplains felt like could be done to help these individuals.
I am curious from hearing all of what you're sharing, Rushil, what exactly are some of the examples of Dharmic faiths, and how would their practices differ that would be outside of the scope of like your average chaplain at a hospital?
Sure. So I think one thing that comes up, so for instance, speaking with Hinduism, like sometimes some of the prayers that are said are in Sanskrit, which is like sort of the language of all the Hindu texts. And one interface issue that can come up is chaplain can try and pray. They may not be familiar with Sanskrit, so they can offer an English translation, which again the patient family may not feel is authentic. Or the second is that the chaplain may try to pray in Sanskrit, but again the pronunciation, the cadence may be off, and the patient's family may not find it as comforting. And so, sort of like the chaplain, all they can offer is sort of like a prayer in English, which again the patient family may not also find comforting at that moment. So I think there was there's some things around language that come up. I think the other piece of it too is the breadth of Hinduism is so I think the nuances within all these traditions is so vast that I don't think the resources the chaplains have on hand may be able to address it. So for instance, if they're asking for scripture, same thing, certain traditions within each of these faiths will accept certain scriptures as sort of something that they read actively, and then others may not accept those same scriptures as well. And then again, the language barrier comes in. So I think those are two big things. And I would say the third thing is definitely the centrality of what we call murtis, at least within the Hindu faith. And so these are images, sacred images that different individuals will look to, not to worship the image, but to remind themselves of God or the divine. And so these objects serve as a way for them to focus their worship without necessarily worshiping the object itself. And I think, I know one of the chaplains mentioned, during the pandemic and trying to get murtis for an individual when their families couldn't come in, they just had to find pictures online to just print and try and have something and to hang up around the room. So I think some of these, it's just, I think proactively what's needed is like the chaplains to sit down with these community leaders to figure out, like, are there ways we can make accommodations for these individuals when they're in the hospital so we can help them in the event that you all can't necessarily make, and so we can do the best that we possibly can.
Considering it sounds like you have a lot of background in Hinduism. Is Hinduism a monotheistic or polytheistic faith?
Yeah, so that's a good question. And I think one of the challenges is to also recognize that the framework of like monotheism and polytheism stems out of, I think, a framework where you had centuries ago European scholars sort of trying to take their, I think, understanding of religion and project it to other traditions. And so I think within the scope of Hinduism, there's this concept of God. Now, some people may identify that as one central God with multiple deities who are all emanations of that God. Some people may choose to identify that as sort of this formless, sentient entity. And then others may actually choose to revere like different figures as individual deities and collect refer to them as God. So there's such a, I've had some of my colleagues in religious studies who've said that the breadth of diversity in Hinduism, it's so vast, because if you look at that subcontinent and how many billions of people that live there, and trying to put it under one category as Hindu, it sort of makes this, trying to answer this question a little bit challenging.
I totally understand where you're coming from on this one. Yeah, it's like you said, the European scholars are trying to understand this other faith from the lens of their perspective. Right. So there's like easy for like misunderstanding. I mean, knowing about the Catholic tradition, because I was raised in that, is there's like saints, and there's angels, there's like the Father, the Son, the Holy Spirit. So a scholar from like a different tradition might look at that as like kind of with a misunderstanding from like their perspective or their lens. So
correct. I think the most, I would say the important thing though is that what is also important to note is the word Hindu is not found in any scripture that we now would regard as Hindu. That word in and of itself, I think, it's a word that was come up with individuals, outsiders, these scholars. And so you can imagine when you use that term to basically lump all these traditions together, it creates a lot of confusion down the road of trying to understand the differences. But I think the one important thing to note here is that despite, there being one label, there was a spectrum of beliefs that could coexist with each other. And I think that's what makes it sometimes so challenging to try and unpack all of this. And, especially for the chaplains who are trying to figure out, like, how can I help this individual and kind of go from there. But I think, once they recognize that there's a spectrum of how people, and that's why I like to use the term God, because God can be one God, can be multiple different individuals that somebody might be revering or worshiping. So there's a concept of God. It's just how people interpret that might differ depending on their individual tradition.
But didn't know a whole lot of like just certified clergy members. They didn't really know much more than that. I wasn't sure if they were like a person of all faiths, but can you speak to faith-based dietary preferences or dietary practices?
Sure thing. I was just going to, building up for last one, I was just going to say, yeah, I actually hadn't really worked with a chaplain or really knew what they did until I was there in New York City. And I think their entire thing is they want to be able to advocate for patients. And I think dietary restrictions or dietary preferences and restrictions is like one area where I think they can be so instrumental. And so, within these four traditions, there's such a spectrum of different practices people may follow, anywhere from avoiding just cow products, since the cow is considered a sacred animal within some of these traditions, all the way to avoiding any form of meat, egg, and even onion and garlic. And a lot of these, some of the more, I think, more stricter regimens, it stems from this idea that there's different qualities in the foods that we consume, and those qualities can then invoke different mental states, which may or may not be conducive to maintaining sort of mental stability and being able to focus and concentrate. And so, all that to say, one can imagine when somebody is ill, and especially if faith is something that's important to them, trying to maintain those preferences when the hospital may not exactly know about them can be very challenging. And I think the pandemic actually made it even more challenging because a lot of times in these situations, the family members would take it upon themselves to provide these meals. And you can imagine if somebody is raised eating like traditional scrumptious Indian food, and then suddenly that they're cut off from that, like it makes it very hard for them to be in the hospital. And even though the food might be vegetarian, it still may not be something that they're familiar or comfortable accepting. And so I think all things considered, this is like another area where even though I myself maintain my own dietary practices, I never once thought, well, what would this look like if I were ever admitted in the hospital until I saw this happening, in the midst of the pandemic and just seeing how people in my own community were being affected by this across the country in different hospitals, even outside of New York City.
I just had one thought. I was just going to say it would be great if the clergymen that they brought in for these other traditions, Dharma faiths, had connection to some sort of food service. Like, hey, would you like to get some of our cultural foods, like delivered to the hospital? Maybe down the line someday.
Yeah, no, it's funny you mention that because after I left New York City, I came to Charlotte, North Carolina to complete my training in hematology oncology, with the goal of becoming somebody who actually treated cancer. And one of the individuals I met in the follow-up project to the research that we did in New York City, working with community members in Charlotte, he himself is like a volunteer. He runs like a daycare a daytime program for senior adults, senior South Asian adults. And during the pandemic, he actually advocated to the local government that these individuals who are isolated at home, they may not have the means to be able, and especially the ones who are sick, may not have the means to be able to prepare food. So he actually got local funding to prepare food that was vegetarian, no onion, no garlic. And he explained like the importance of these preferences, the significance of these preferences to the county officials. And so he was able to get funding to do this and provide these meals and that he would deliver himself to the different homes. So it's definitely a need that I think obviously is not just important for people in the hospital, but even as they're going through cancer treatment, I think these are considerations that we don't highlight them proactively. They can create a lot of harm. It actually reminds me of another example where another gentleman, he had advanced pancreatic cancer, and they often, when the pancreas no longer is functioning, it's hard to digest food. And so the enzymes that they give, they're given capsules. And capsules, as any pharmacist would explain, contain gelatin, which is an animal product. And so this gentleman, he suffered, he lost weight because they could not find vegetarian equivalent capsules that contained the pancreatic enzymes. And they existed, but the only way they found it wasn't through the healthcare system. It was through contacts that he had within his family who were healthcare professionals. And so I think all in all, this is like a big area that I think is going to become increasingly important to address, especially as we're seeing so many immigrants coming from South Asia and settling here in the US.
And you had mentioned earlier the kind of the biomedical model. I just wanted to ask a question on, historically speaking, the patient religious needs towards the end of life kind of had poor outcomes. Just wondering if you could just sort of speak to distress or to that domain.
Sure. And when you say distress or domain, like, your time, is that sort of kind of how we think these are related, or like
just how
unmet needs?
Perhaps that intersection between a religious need and at that end stage of life.
I see. Okay, sure. So yeah, definitely would say, I think And when I reflect on my own training, I don't think even in those 4 or 5 years of medical school, there was really little to none that was even taught about faith, religion, and how it intersected with care. And I think the closest I would have gotten would have been that third year of where you see this come up, patients with advanced illness of any kind. And there was actually a study that was done, it's probably about 10 years ago. It's called the Coping with Cancer study, where they followed individuals with advanced cancer in different parts of the country, around 300 to 400 adults with cancer. And what they identified was the individuals who were very well connected with the faith group. Those individuals didn't feel like the healthcare system was meeting their needs. They actually ended up having more intensive care at the end of life. The things of being in the ICU, being intubated, CPR, all those advanced life sustaining interventions, just because they felt like the healthcare system wasn't meeting those needs. And I really think when I take a step back, those my experiences, what I know, it almost feels as though there's no means of coping that are yeah, there's basically a lack of source of coping that these individuals encounter. And so in the moment of distress, right, like when you're being told that you're not going to survive this, or family members are told that this individual is not going to survive this, not having a way to cope with that kind of information may in turn make it hard for them to make some of those tougher decisions for focused care. I think that's one aspect of it. I also think the other aspect of it is to make meaning of life and death. That's something that faith offers that medicine cannot offer, just because it's the focus is very, very different. And I think that's one of the tragic consequences of this fragmentation, where everything has become so disease oriented, technically oriented. So we have all these newer and newer therapies, but at the end of the day, life and death, these are things that are going to occur through the natural life processes, and without any kind of framework things, it makes it very hard. It's sort of like the why. Medicine can answer, how we treat things, but the why answer the question of why do things happen and so forth. I think the system of medicine that we have, it's not prepared to answer those questions of why and make meaning of all that.
I was curious if you could just maybe speak to the contemporary research on the topic, or if maybe that is something that you feel like you did address with that study you brought up.
Yeah, actually, there was, for people who are interested in this space, so the Journal of the American Medical Association, or JAMA, in 2022, they put out a systematic review of literature in this space. A systematic review, for those who might not know, it's basically a summary of all the studies that have been done in the space of religion, spirituality, and the impact of that serious illness, serious life-limiting illness. And so they reviewed, and this was like a group of basically one can imagine there aren't that many people doing this kind of research that are within the medical space, but these are the seasoned and senior investigators. And so they ended up scouring, I think, years and years of studies, and they managed to identify 370 studies, and they reviewed all of them just to see how strong were they designed, what were the conclusions. And I think it was very clear, there was very clear evidence that supported 6 recommendations that they decided that they put out, that 3 recommendations for clinical care and 3 for healthcare outcomes. Within clinical care, it was very clear that when we incorporate spiritual care into people with serious life-limiting illness, it is something that not only addresses what individuals want, but also has an impact on their outcomes. And obviously, so that was one, is to make sure you incorporate spiritual care into patient care. 2 was to actually train teams. So chaplains are certainly the spiritual care specialists. At the same time, due to staffing and budgeting issues, it's hard to think that everyone that has any kind of unmet spiritual care need has to be triaged to the chaplain, who may not always be on service. And so learning what are the aspects of spiritual care that I as a physician can do, or I as a social worker can do, or I as a nutritionist can do. And then if there's certain things that I can't address, knowing when to refer to the chaplain. And then which brings to number 3 is involving chaplains on teams. And I think in palliative care, because of the patient focused approach, it's sort of a no brainer to involve chaplains. Same thing with hospice agencies. At the same time, like I don't think people think about, hey, let's have a chaplain on our heart transplant service or bone marrow transplant service. I don't think we're at that stage of care where people recognize that role on these teams. So I think those are three main recommendations they had for patient care. And with outcomes specifically, I think if you could summarize all three of them, really it was to basically acknowledge people's faith, participation in faith activities like in the community, be it at their place of worship or support groups of individuals of the same faith. Because if the failure to acknowledge that, clearly you're cutting people off from a very critical psychosocial support system that has been shown, by the study that I mentioned previously, to actually influence how people do in the hospital and with long-term outcomes. So I think now people are becoming more aware of sort of the social context. We hear about social determinants of health a lot. And if you look within their faith, like church or faith-based, community faith-based organizations are certainly there. I just don't think that's been an area that a lot of people have explored. And certainly it opens up avenues for interesting questions for people to offer and ask.
Yeah, I think in speaking to those social determinants of health, I was going to ask what cultural disparities have you seen in palliative care, and perhaps how does that affect those outcomes?
Sure. And I think the story that I shared earlier with miracles invoking and like invoke language around God and miracles, I think is a very, very good example of this. But I think for starters, I always like to ground myself, kind of in like a definition and sort of what's the difference between culture and religion. And, I think culture is sort of this, I like to think of it as a higher level term where we're looking at, how different historical, political, social forces are shaping a system of beliefs, values, and lifestyles of various individuals, how they make identity out of those factors. And certainly religion is a part of culture. So if we're seeing issues emerge because religion and spirituality aren't being acknowledged, then we can see how that translates to cultural disparities. And I think with being here in the South, where there's a lot of language around miracles happening, waiting for God to work a miracle, I would say I've seen situations where, even though it's very clear that there's no additional medical therapies that are going to improve somebody's condition. I think because of the training that we get in it as a physician, and not preparing us to address that language of God and miracles, it makes it very hard to signal to people and to help them cope with this tough situation that now I have somebody who is very close to their end of life, if not at the end of life, and all these things that we're doing are not helping them in the way that we would like to help them. And I think sometimes it becomes what it turns into, it becomes this friction between, the scientists, medicine, the doctors are speaking in science, the patients and family members are speaking in religion, and we can't understand each other. And I think this is where we start seeing some of these differences in end of life care outcomes, and we start looking at different cultural minorities here in the US, because faith is sort of what I see as a construct that transcends a lot of these different communities. And it's just the inability of our system to prepare clinicians to help navigate those conversations that I think, unfortunately, can sometimes lead to bad outcomes. I think there's one piece of that. And I think there's other cultural systems which they actually would elect for more intensive care at the end of life, where I think sometimes the clinicians struggle. Like there's a sense of moral distress where I know this person's staying on intubated or getting put on feeding tube is not going to improve their longevity. But I think there's ways that an individual can still offer space for somebody to wait for a miracle and hope for God to do what they're trying to do, while at the same time communicating that, hey, look, these things are going to happen independent of what I do as a physician, as a clinician. I just would be amiss to subject your loved one to the complications from remaining on these treatments indefinitely, because there are some real risks with staying on these treatments. So, I think there's ways we can communicate these things, like prognosis is poor and that we have some significant concerns with continuing treatment indefinitely without disrespecting people's beliefs and values and preferences.
Yeah, everything you've shared is very important in approaching care. I did have one last question for you. Can you tell us about the Spiritual Theology and Health Seminar?
Sure. And is this the one, the Duke University? I can't remember.
I believe so, yeah.
Sure. So this was actually, it's a course that's given every year. It's led by Dr. Harold Koenig. And really, it's sort of like a retreat actually held in once a year. And basically, people of any discipline at any stage of training is welcome to come. And really, it's just to try and orient individuals to what research has been done with religion and spirituality within healthcare. So I attended the 2022. I was in the 2022 cohort, and there's a lot of reading. Again, people come to it with different levels of interest, but there was a 500-page textbook that was assigned as reading in advance of the course, which I highly recommend if anyone is interested in learning more about this space or wants to do research focused in this space. It's a very open space. There's obviously a lot of unanswered questions, but that reading that you did in advance is so helpful, because during those 5 days that we're in the retreat, Dr. Koenig just goes through each of those chapters more in depth. I think he basically goes through kind of what has been done, where does the field need to go, what are some criticisms people have raised in the past, why those criticisms are faulty, and then how can you support yourself in trying to do this work. So again, it's open to anyone. And I think they have scholarships too for people who are coming from other parts of the world. So it's it was in my cohort, we had people coming from South Asia, Southeast Asia, South America, Africa. I mean, it was really an international experience. So highly recommend it for those who are interested in this work.
Well, Rushil, we really wanted to thank you for your conversation today. I really enjoyed hearing your expertise and bringing so much of yourself to your field in hematology and oncology. So thank you so much for being here today.
Well, thank you all for having me. I appreciate the opportunity and privilege to be able to share what insights I have as I'm still continuing to learn and grow in this space.
Our podcast will discuss topics related to cancer treatment and the recovery process, including diagnosis, family support, resources, medications, and nutrition. We aspire to have conversations pertinent and relevant to the cancer journey. Thank you for listening to the Sick and Good podcast. We'd like to invite you to connect with us on our social media at Instagram and Facebook accounts. We're also happy to share that we have launched the Sick and Good podcast website, sickandgood.com. This website is a place to read our bios, subscribe to the podcast, listen to full episodes, or read full transcripts, and contact us with your questions or comments. We care about your listener experience and would love to hear from you to keep the conversation going on the topics of cancer and wellness.